Hey everyone, this is Alex. I'm in the pathologist assistant program at Tulane, and today I'm going to be talking about liver pathology, specifically viral hepatitis C infection, which leads to fibrosis, cirrhosis, and could potentially lead to hepatocellular carcinoma. So, hepatitis C is a viral infection, and most of the time it is spread through shared needle via intravenous drug use. Other forms of transmission would be sexual contact with an infected partner, transfusions, although this is diminished a lot now that we have proper screening and regulations set in place. Needle stick injuries in a hospital setting, and mom's transmission to baby via birth. And the important thing here is with viruses, I don't think a lot of people realize that viruses have this way of exerting things on the cell that can potentially lead to downstream effects of cancer. So, hepatitis C is one that can lead to hepatocellular carcinoma. But let's not forget that things like human papillomavirus, HPV, which is vaccine preventable, can lead to cervical cancer in women and head and neck cancers in men. Epstein-Barr virus can lead to some lymphomas and head and neck cancers. HIV can lead to Kaposi sarcomas, and HTLV can lead to T cell lymphomas. So it's important to understand the role of viruses and what they can play in tumor genesis. So, the stats on hepatitis, over 71 million people in the world have chronic hepatitis C infection. In 2015, the World Health Organization estimated that there were 1.75 million new infections in the world for that year. And in 2016, globally, 400,000 people died of cirrhosis or hepatocellular carcinoma due to a hepatitis C infection. In the United States, hepatitis C is the most frequently reported bloodborne infection, and it's the highest in the baby boomer population, which is anyone born between 1945 and 1965. In 2010 in the United States, 3.5 million people had chronic hepatitis C infection, and the numbers have been rising because of the opioid epidemic. Actually, they say that up to triple the amount of cases. And hepatitis C is the leading cause of liver transplants in the United States and is the second leading cause for hepatocellular carcinoma. Hepatitis B infection is actually the first cause. I guess reasoning for a person having hepatocellular carcinoma. So it is a bloodborne virus. The most common mode of infection is, again, through small quantities of blood with the IV drug use, and it is a small enveloped and single-stranded positive sense RNA virus. So some symptoms of liver disease: acutely, like upon onset of liver disease, there could be some jaundice, either in the skin, in the sclera, and the eyes. There are fever, vomiting, and potentially dark yellow urine. And once you get to that chronic setting, you might see things like these little spider nevi or spider angiomas. And so whenever you get to this cirrhotic stage of in the liver, the liver can secrete things like vascular endothelial growth factor, or VEGF, and basic fibroblast growth factor, or BFGF, which have been found to be elevated in cirrhotic patients. These growth factors can play a role in formation of the spider angiomas in patients with liver cirrhosis, so that's something to be on the lookout for. Other things like ascites, edema, fluid retention, portal hypertension, so that's from having increased pressure in the liver, and so that can cause that blood to back up. You could have things like splenomegaly or esophageal varices, which are like these little outpouch, I guess like little veins that are in your esophagus that could potentially rupture. So just things to be on the lookout for once you get to that chronic disease. Diagnosis and treatment for liver, anything in the liver. You're going to want to look for elevated liver enzymes, things like elevated AST, ALT, ALP, bilirubin. And if you know that they have hepatitis C, it's good to check their viral load and their viral genotype. And so the question becomes, who should be getting tested for this? And the answer is really we should be having universal testing for this. Now that we have the means to pretty much cure hepatitis C, they have had a lot of advances in the past 10 years for hepatitis C treatment. Anybody could be walking around with hepatitis C. It's unfortunately a disease that, although I just read some of the symptoms to you, a lot of people don't really present and don't know that they even have it. And so they might go around for 15, 20 years with this hepatitis C infection, and their liver is becoming fibrosed and cirrhotic. And it's something that if their primary care physician would have just, ordered, ask them if they wanted to get tested for any infectious diseases up front, it probably could have prevented this from getting so bad. So one thing is that pregnant women always get screened for sexually transmitted diseases and hepatitis and all that. So that is, one population that is kind of like getting constantly checked. Once you know that you do have hepatitis C, it's important to get established with the correct physicians. So, having an infectious disease specialist on hand and seeing a hepatologist frequently. I think they probably have you come in every 6 months or at least once a year, and you should be getting regular ultrasounds to look at your liver so that you can be on the lookout for that fibrosis, that cirrhosis, the HCC, and liver failure. And again, like I said, while there is no vaccine for hepatitis C, so you can't really vaccinate to prevent it up front, there are antiretroviral drugs that can clear the viral load after the fact if you meet the criteria. So basically, and there's a long list that I'm going to read, but I think it's important. Anyone who's ever injected or inhaled illicit drugs, anyone who has had abnormal liver function test results with no identifiable cause, babies born to mothers with hep C, healthcare and emergency workers who have been exposed to blood or accidentally stuck themselves, people with hemophilia who were treated with clotting factors before 1987, people who have undergone long-term hemodialysis treatments, people who have received blood transfusions or organ transplants before 1992, sexual partners of anyone diagnosed with a hep C infection, anyone with an HIV infection, anyone born during that quote unquote baby boomer timeline from 1945 to 1965, and anyone who's been to prison. So that's a lot of people, which is why PCPs should just be asking upfront, have you ever been checked for hepatitis C? Yes or no? If not, let's just go ahead and, get a blood sample. It's as easy as that. Because hepatitis C, if, left to just fester, will turn into fibrosis of the liver. And so this basically is just the liver scarring itself because of repeated inflammation, repeated long-term damage. And so you have this scar tissue that's replacing the liver cells, and the damage can't be reversed if it's being repeated over and over and over again, especially if this is going on for many, many years. And so you start to destroy the internal liver structure, the liver function, and it's pretty diffuse. So it doesn't just stay in one little side of the liver. It kind of just takes over the entirety of it. And there's different stages of fibrosis. So stage F1, which is mild, would be just portal fibrosis with no septa. Moderate, you kind of move up with some infrequent septa. Severe, you move up to numerous septa, but not quite cirrhosis yet. And then the last stage is you have started to develop cirrhosis. And so that's why it's important to keep going and doing those abdominal ultrasounds so that you can be seeing when the patient's moving up from mild to moderate to severe, oh, they have cirrhosis now. So it's important to just be aware of that and be aware of your body. And then if you need to do a biopsy, certainly you can do a liver needle biopsy, but I think the abdominal ultrasounds suffice and they're not as invasive. So to each their own. People with fibrosis are usually unaware that they have it. It's not until they start to get cirrhosis that they start having those really, really bad symptoms where they're having the varices, they're having portal hypertension, they're having hepatosplenomegaly, encephalopathy. So Once you get to that stage of cirrhosis, so this is end stage fibrosis is what turns into cirrhosis. And this is just marked severe scarring of unchecked fibrosis. So you get this nodular appearance. This is due to regenerative nodules because the liver is just trying and trying and trying to repair itself, and it's just not happening. This develops slowly, takes a really long time to get to cirrhosis. So you're meeting up with your hepatologist a lot, and you're staying on top of everything you need to do to not further I guess exacerbate your staging. So staying away from alcohol, staying away from smoking, doing things that are going to keep your liver nice and healthy. So the flow of blood through the liver can start to become blocked, and that's where you start to get that portal hypertension. The compensated liver cirrhosis just means that the liver can still function normally despite the damage that's occurring, whereas decompensated, you now have severe symptoms, and you're starting to get to that point where you might need a liver transplant. So this is an example of a cirrhotic liver. You could see those nodules all on the surface. Right, both in the parenchyma and on the capsular surface, they're kind of just all over the place. It's diffuse. And then this little part right here, this is all gallbladder. Gallbladder usually doesn't look so much like this, but that is a gallbladder. And it was a very enlarged liver too. So you can see here cell-wise, you start to have marked fibrosis and banding between the hepatocytes. You can use a trichome stain to look for the fibrosis and the collagen deposition. This is a special stain that the pathologist would need to order, but it's a common stain to use with liver cases. And histologically, the cirrhosis is characterized by these vascularized and fibrotic septa that have portal tracts that are linking together. And the hepatocytes form these little islands that are surrounded by this fibrous septae, and you don't really see like a central vein. It's just a lot of fibrosis. So things to be on the lookout for if you have liver cirrhosis. It's important for your hepatologist to be screening for and listening to you to find out if you could be developing some of the more severe things like portal hypertension, splenomegaly, the variceal veins or esophageal varices, encephalopathy, edema, ascites, and of course, hepatocellular carcinoma. Which hepatocellular carcinoma is more common in men than women, about 2.5 times more, and typically arise in the 4th to 5th decades of life. So again, you have this kind of long withstanding relationship with this hepatitis, the fibrosis, the cirrhosis. It kind of takes a while to get to this point. There's a 2 times risk for African Americans, and the distribution of hepatocellular carcinoma mimics hepatitis infections pretty head on. Wherever you're going to have a lot of hepatitis infections, you're going to see patient populations with hepatocellular carcinoma. The mass itself typically presents like a pale yellow or green. It could be a single discrete lesion, or it can be a diffusely infiltrative lesion. But if it is a lesion or any lesions larger than 2 centimeters, you want to be on the lookout for vessel involvement and be able to document that in your pathology report and your cancer checklist, because it's very important for staging. So the classic histomorphologic features of hepatocellular carcinoma, which is the image on the left, are well-vascularized tumors with wide trabeculae, acinar patterns, cytologic atypia, and mitotic activity. And there's also an absence of Kupffer cells. So you also don't see as much reticulin networking, whereas on the image over here, which is normal liver parenchyma, you have your hepatocytes, your sinusoids, you have your central vein, so everything kind of looks like nice and clean, whereas the image over here just kind of looks like a mess. Treatment. So Again, this is pretty new in the medical, I guess in the medical world. In the past 10 years is pretty new. There's antiretrovirals. So there used to be maybe like one or two, and then they have expanded to a lot of different companies that now produce these. It used to be that only certain genotypes were available, like the medications would only treat certain genotypes, but I think now they pretty much have medicine for any genotype because there are one, two, three, four, five, six genotypes, although in the United States, the most common genotype of hepatitis C are types 1A and 1B. Up to 75% of infected patients in the United States, that's their genotype. And it also depends on the amount of viral load, so that when they check the patient's viral load, if it's too low, they might not be eligible for treatment. If it's too high, they might not be eligible for treatment. And if they have done previous treatment before, and if the patient didn't adhere to the treatment, it's not uncommon for their insurance company to deny them payment for, like, paying for a second treatment. And then the one that I'm familiar with is Harvoni. So Harvoni, it looks like you can use with a few different genotypes, and you can use it if the patient doesn't have cirrhosis, or if they do have cirrhosis, it looks like you have to take it in combination with another medication. But they've improved a lot over the past few years, and I think that it's great that these people are able to be cleared of their virus. And it helps out epidemiologically because they're not going out and spreading this virus to everybody else. So Louisiana, I thought this was kind of exciting. In Louisiana, they are really big on trying to get the rates here as low as they possibly can. So anyone after, let's see, summer of 2019, if you're a Louisiana Medicaid beneficiary, you can get hepatitis C antiretroviral treatment at no cost to you. And it's really, really, I think that's really great. So I put the links here. If you live here, if you know somebody, if you want to just spread the word, I think it's really great. I know somebody that had no idea that they had hepatitis C, and their primary care physician just asked them if they'd ever been tested for it, and they said, no, I haven't, but sure, fine, test me, I don't care. And then they ended up having hepatitis C, and which is kind of why I chose this topic, because this was someone close to me, and I didn't know they had hepatitis C. They didn't know they had hepatitis C. And then they ended up having fibrosis of the liver and all kinds of other things, underlying things that we didn't know were there. And she has been able to get treatment for free through this program, and she doesn't have hepatitis C anymore. So I think it's really great, and I just wanted to share it with everybody. And thank you for coming to my talk.